Welcome everyone to the CUNY School of Public Health Grand Rounds. For those who don't already know me, I'm Elizabeth Kelvin, and I'm the chair of the Department of Epidemiology and Biostatistics. And each year, each academic department at our school is invited to nominate someone to speak at Grand Rounds. In the Epidemiology and Biostatistics department, we try to identify speakers within our three disciplines and alternating years. So that includes epidemiology, biostatistics, and health informatics. This year, our speaker is a leader in the field of health informatics. And just as a heads up, following the presentation, one of our population health informatics faculty members, Dr. Flores Arango, will lead the question and answer session. So now I want to welcome our speaker, Dr. Kenrick Cato. Dr. Cato is an assistant professor of nursing and clinical informatics at the Columbia University School of Nursing and the School of Physicians and Surgeons. His research focuses on the mining of electronic patient data to support decision-making for clinicians, patients, and caregivers. And today he's going to talk to us about the CONCERN study and findings regarding clinician bias. Welcome, Dr. Cato.
Thank you so much. Let me get my presentation up here. Can you see my screen?
Yeah.
Great. So it's my honor and pleasure to be presenting to you just some of the things that we've learned about clinician bias during the CONCERN study. And I will describe what the CONCERN study is in a second. And I don't think I need to explain my affiliations. My spouse and I have no conflicts to disclose at this time. So this is the general agenda for my talk. I'm going to talk a little bit about who I am, why am I here, some of the theoretical frameworks that share my work, that frame how I do things, the CONCERN study, and then some experiments that we did in the CONCERN study, and then why does it matter? So I think context is important. So I'll start with who I am. And this is, everybody's got a mental model of who they are. There are a couple of things I left out here, like I really like dogs, but I didn't put that in here. But I'm a veteran. So, and I have that first because I did a lot of things before I joined the Army, but I joined the Army when I was 25 years old after college. And it really shaped. I was a young man then, and it shaped how I see the world. And I spent 10 years as an infantryman, both enlisted and officer. And so, it's just kind of part of who I am forever. I'm also a nurse, clinical nurse. I worked as a cancer nurse, oncology nurse for many years, and also in the emergency department. I'm a technologist. So I've been writing code since I was in fifth grade. I've started a couple of technology companies. Night Kitchen Interactive is a company I started actually before I joined the Army. So I did technology stuff before I got into the Army. And then afterwards, Team of Care is a care coordination software company that I helped start while I was getting my PhD. And then finally, the thing that I spend most of my time these days doing is I am a researcher and an educator. So my program research really focuses on applying data science methods to electronic patient data to help support clinical decision making. And you'll see a little bit of what I mean by that kind of long sentence. And I also train graduate students and postdocs, master students as well in clinical informatics methods. And I also consider myself a nurse researcher because wrapped around all of that is trying to figure out some things that are specific to nursing science. So why am I here? So most of you or all of you are in public health. This slide probably this information is not new to you, but it is something that it's important to me and it's important to my work. I was trained here at Columbia in the Center for Applying Informatics to Health Disparities. That was the NIH training grant that I had as a graduate student. And I've really focused on using informatics to provide safe and quality care to individuals, but also to provide non-biased and effective care to all members of our community. And so the fact there's lots of reasons why non-white patients have worse health outcomes, but one of the things I'll talk to you today is just some of the what I see as bias that we found in clinician workflow that I think also contributes to these health outcomes. So so I think it's important for you to see kind of the driving theoretical framework that drives most of my work. So this is from a manuscript that I published with a couple of colleagues. Kathleen McGraw is a Chief Nursing Informatics Officer at Microsoft, and Sarah Rossetti is an associate professor here at Columbia University. This is the data information knowledge wisdom framework. The data information knowledge framework came from computer science, and then nurse informaticists got a hold of it and added the wisdom onto it. What you see on the left, so we thought about this because actually a lot of nursing leaders were coming to us and asking us questions about, and us being the co-authors of this paper, from different directions about how they should be thinking strategically about artificial intelligence and clinical decision support. And so we adapted this framework. So on the left is really telling people, what is appropriate from a strategic thinking standpoint, short-term, long-term. And then on the right are some of the needs or items that you might consider in these different levels, and layered on top of the data information knowledge wisdom framework. And this pyramid, what this pyramid basically says is that you have a lot of data, and you need to, in order to make that data into information, there's some kind of curation that needs to happen. There's computational or human curation needs to happen. And then you really want to take that information and turn it into knowledge. And that takes another layer of curation and work. And then finally, in the long term, you want that knowledge to be wisdom. And when we think of wisdom, what it really looks like operationally in the long term are things like predictive analytics, personalization for clinicians, personalization for patients according to their patient preference, and then also according to some of their social and behavioral determinants of health. So that's where we hope to get to, and that's where my program research hopes to get to in the work that I do. So just a little bit of background about the Concern Project and the significance of it. So the Concern Project actually is the one that I'm going to show you. We actually have two Concern projects, one for the inpatient setting and one for home health. But the one that I'm going to talk about is about inpatient and some of the stuff that we found there, because that was where we did our bulk of modeling. And so for Concern inpatient, these are some old numbers, but we know a lot of people die in the hospital, and we consider these deaths preventable deaths. In the sense that if we had clinical decision support that could predict that a person was declining in the hospital, a clinician can intervene early, and we have a lot of tools to intervene early and hopefully prevent some of those deaths. And so at the same time, our team's research has shown that nurses, because they spend a lot of time with the patient, they detect subtle changes in the patient state, especially in deterioration, and they react by increasing their surveillance. So, and so the ways that they react, and you can see this, it's reflected in the documentation and what nurses do in the electronic health record. At the same time, we've also seen there's a difference between physicians' expectations of physiological change and nurses, meaning that physicians are a lot more objective in their assessment of patients. And so when nurses and physicians try to communicate around patient deterioration, there's often suboptimal interdisciplinary communication, and that's what Concern is really focused on. So what is Concern? So it's a couple of things. So it's an early warning system. In the world of clinical informatics is this idea that you can create early warning systems that will take data and let people know early about some concept, and this concept is deterioration. And so we base our early warning system on signals from nursing documentation patterns, or factors of nursing documentation patterns. We do something a little different. There are other early warning systems that use patient-specific data. We actually try to model, and they try to model if a patient's going to deteriorate. We try to model nursing expertise. So we try to model what a nurse is thinking and behaving when they are concerned about a patient. And our work, we think it's great because it actually has been shown when compared to other early warning systems, it fires early, 48 to 24 hours before the deterioration event. And when I say deterioration event, I mean things like the ultimate event, which is mortality, also sepsis, unexpected transfer to the ICU, rapid response being called, or a cardiac event occurring. So that's our composite outcome for deterioration. And then finally, I also do work around documentation burden as well. And it was very important for our team to make sure that in whatever system we created, we weren't going to be adding any additional documentation. So we use existing interactions, nursing interaction with the EHR. And this is really important because there are systems that ask nurses to add additional documentation, or clinicians to add additional documentation to provide early warning. So the concern stands for communicating narrative concerns entered by RNs, registered nurses. It's a multi-PI project funded by the National Institute of Nursing Research. Sarah Collins Rossetti is my co-PI. It's an MPI project, and it's actually a multi-site project between Columbia University and Harvard University, New York Presbyterian Health System, Mass General, Brigham Health System. We have a large interdisciplinary team. Sarah's the one who came up with the great name Concern, so I have to give her credit for that. But the reason communicating is in, even though we're doing modeling, is at the base of it. Both Sarah and I came to this research trying to communicate information about the patient that we detected from nurses to the rest of the interdisciplinary team. So the Concern study, it's actually it's a 6-year study, and we have three aims. So our first aim when we first started was to do analytics on a large set of data from both Harvard and Columbia to build predictive models to basically predict deterioration. We employed a couple of informatics data science methods. Natural language processing is one of them, where we use that to go into notes and pull out information that humans have written that a machine can understand. If you've ever spoken to a smart speaker, then the smart speaker is using natural language processing to understand what you're saying. We do the same thing for written language. So we built natural language processing pipelines to pull out data from notes, and then we did machine learning to build predictive models, both on structured data and also the natural language processing variables that we extracted. And what I'm describing was a 2.5-year-long process, working with clinicians to understand the concerning concepts that they document, and then doing machine learning to identify those concepts, and then doing the modeling, additional machine learning modeling to do prediction. And so after we did that, we employed user-centered design to build the clinical decision support app that, and we call it a smart app because it uses a technology called Smart that allows you to launch software out of electronic health record, but it looks to the human or the user that it's embedded in there. And then we also did focus group testing to understand where in the clinical workflow this information should go and how it should be triggered. And we did simulation testing to confirm all of that. And then finally, we had a randomized controlled trial, both here at two hospitals, a large academic medical center and a small community hospital here in New York, and the same in Boston, large academic medical center, and then a small community hospital, the Brigham and Newton Wellesley being the small community hospital up in the Boston area. And, our primary outcome is really mortality in the randomized control trial. Will be done in a week. On Halloween is the last day of our randomized control trial, a year long here and a year and a half long up in Boston. And we're looking at some other outcomes like length of stay, cardiac arrest, unanticipated transfer to the ICU, things like that. And there are lots of other things that were other outcomes or other kind of concepts that we're also investigating, like basically how do clinicians interact with the concerned clinical decision support system? What do they do after and before? Things like that. So one of the things to point out about the risk prediction is that we actually originally were going to create a score, and we still do create a score. But in doing focus group testing with both nurses and physicians, they said they didn't want a score. They wanted to see concern levels. So concern generates a score, and then it's translated into low, medium, high risk for deterioration. And then also when we were doing our focus group testing, clinicians told us that they actually were really good at identifying the high risk and the low risk, but not so great at the people in between that had increased risk. So that's where they wanted clinical decision support. So all of our modeling, all of our thresholds in our model were maximized to be able to identify those types of patients for the clinicians. So this is what concern looks like in the EHR. So if you've ever used an electronic health record, all of them have a patient list, tells you which patients you're interested in. Both the nurses and physicians said they wanted to see concern in the patient list because that's where they go to. It's a central point. So we configured a concern score column in the patient list. And we actually, the data is, so this is the actual electronic health record functionality. And we're writing data into electronic health record, and it's picking the different color icons that it's going to display based on the data that we're writing into the back end of the electronic health record. If you're a nurse or a physician and you want to know more, so one of the clinical informatics concepts that we held to here was we give the user the most amount of information they need in their workflow without disrupting their workflow. So if they're just looking at this, they see that a patient is at a certain level. You might see a little dot or asterisk right next to the icon that tells the user that the levels actually changed since the last time we calculated it. Every hour we use the last 24 hours of data to calculate the concern score. So this gives the clinician a lot of information without having to go further down or do any more clicks. If they want more information, they can then launch into our application, which for the user comes up in the EHR. We use a standard called FHIR, which is a way to build software once, and it actually works in all of the major EHR systems. So we built this app, and what this app is doing is it's actually doing a couple of things. It's giving the prediction in a non-black box way. So in the center here, we have what we call the factors breakdown or the factors pane. And we've actually taken the variables or features, and there's close to 200 of them. And we use a method called what-if analysis to actually group them into buckets or clusters. And these are the buckets of variables. And our analysis can then tell the clinicians which of these buckets of variables at every hour is contributing to, how are they contributing to the concern prediction? And that's what this gray line underneath each of these buckets or bullets show you, how much, based on the length, it shows you how much, for example, nursing note content is contributing to the concern score for this hour. There's also trending, which was really important to the users, so they could toggle to see different time periods. And one of the other things that was really important is this is a centralized place in the electronic health record where clinicians can, in a contextual way, get the information about the concern prediction. So, for example, medication administration, physicians said to us, it's hard for me to understand what medications were given for this patient. So if they click on this, in addition to knowing how medication administration, the signal, because we did, in our modeling, we did find that there was signal in those data points, they can click on it and actually see all the medications that were administered. And the same thing for notes. And then finally down here, clinicians wanted to see where in the distribution of patients, and we have a different model for ICU patients as opposed to med-surg patients, but within those two different settings, if you're a med-surg patient, where in the distribution of all the med-surg patients are you for the concern level? And that was actually more important to physicians than it was for nurses. So this is our clinical decision support intervention. So I wanted to give on the front end just a quick introduction to the end product that we have in our randomized control trial, so that you could see, you know, what we spent all this time building. So we also created a unit level roll up for managers. They wanted to see, and they use this for kind of acuity scoring and staffing. And this is actually in another part of the EHR, specifically in Epic, so that they have a quality dashboard where they can see per unit, you know, what are the distribution of concern scores, what do they look like by number. So I wanted to just, you know, show you that up front. Now I'm gonna kind of step back a little bit and talk about nursing documentation and why we're using nursing documentation and why we're using nursing data. So Ripsec and all in 2011, right around when we were doing, Dr. Rossetti and I were doing some separate research, but the same topic about nursing expertise and how nurses communicate their expertise. His group published an article looking at clinician documentation. And they were looking at who reads clinician documentation and at what rates. And so in this very simplistic picture, you can see that nurses spend the most amount of time with the patient, and where they put their expert opinion about the patient is in documentation. And what Ripsec's article found was that nursing documentation was read at the lowest rates of any other type of clinician. And furthermore, not even other nurses read the documentation. So often when a nurse wrote a note, no one else ever opened it. And so we really wanted to find a way to surface this expert, what nurses were putting in their notes, which is their expert opinion about the status of that patient or this patient's clinical state. And we also knew that there would be bias in the documentation. And when I say bias, I mean bias in a positive way, in that, you know, anytime you're trying to do modeling, you need bias in order to create prediction, in order to detect differences. And we knew from the qualitative research that we did that nurses were saying that they write it, the actual content of the note is different if they're concerned about a patient, and even possibly the length of the note. There were different characteristics of the note. And so we wanted to leverage that bias. And so we did a study that Sarah and I published a long time ago. This study, basically we took nursing documentation for patients that had a cardiac event. And then we went backwards to see if the pattern of nursing documentation was predictive of the future cardiac event. And we found that in free text comments and other optional documentation that that there was a statistically significant difference 24 to 48 hours before the event, not just in the content, but also in the pattern of nursing documentation. And so that's what started our journey into modeling this. The concern model itself uses these buckets of information, and that's reflective in the front end app. So we're using vital sign frequency as well as vital sign time. One of the things I didn't mention is this kind of prediction is a time. So this is a time varying process that's happening. And so we had to come up with modeling that was time varying to reflect that. And so for us, the value of the vital signs is less important than the amount and when it's actually done in the day. So we actually ended up modeling every hour of a nurse's day, and created distributions and models for each hour, for each setting, and for different types of patients. I mean, mostly how long a patient had been on the unit, because nurses, when a patient's deteriorating, the nursing behavior looks very different when a patient's been on the unit for just 5 hours as opposed to when they've been on the unit 3 days. And so all of that, these features reflect all of or variables reflect all the information we needed to do that kind of time varying prediction. And you can see we use medication administration record, frequency, nursing, just the frequency of nursing notes, the content of the nursing notes. I mentioned natural language processing or NLP, and then patient demographics as well. And that all goes in the model. We did a couple of different modeling approaches, but the model that ended up working the best was a boosted decision tree model. And this is actually the average performance of the models, because we actually, as I mentioned, we have over 1,200 models, and we end up having all of those models because it's specific to, we have one model per hour, and then different set of models in the ICU and in med-surg, and then we also have different models based on how long a patient's been there. So at the end of the day, we end up with these models, and the system, there's a back-end system that's figuring out all these characteristics for a patient, and then picking the appropriate model and running their data through the model. So I'm going to change gears a little bit and talk about 3 experiments that we did. And we did a bunch of them, but I'm just going to highlight 3. And some are published, some are not, or we presented some at conferences as well, to really understand bias in data. Because one of the things, so I was leading the computational part of the study, the data modeling part of the study. And one of the things, when we were doing quality checks of our data here at Columbia and at Harvard, we very quickly saw some real disparities or bias in the data. And what I mean by that is that we very quickly saw that the data for white patients look very different than the data for non-white patients. And even by what we call the weight of the data, there was actually, for a white patient that had a deterioration event, one of the deterioration events that I mentioned earlier, they actually had more information, more data in the EHR, in the electronic health record, than non-white patients. And so we did some experiments to try to understand that, characterize that, and make sure that our modeling didn't reflect those biases. And so I'll talk about one. So this is a paper that I published with a team at MIT, and we were interested in, so MIT has a public data set called MIMIC, spelled MIMIC, And what they've done is taken a hospital system's clinical notes, de-identified them, and put them out into the world to do research on. And Mimic started out with just ICU data, but it also has other data in there now. And so we wanted to compare what we were seeing in our data with the Mimic data set. And so one of the questions, so we basically took a large data set of Mimic data, and I took a large data set of Columbia data going from 2001 to 2012 just to match the Mimic data. And it was mostly ICU patients. We did include neonatal ICU, so there were pediatric patients that came from the NICU. And then we classified the outcome, we classified patients as white or non-white. And so the data science question we asked was, can we predict the race of the patient based on the content, the free text content of the note? So we took out all of the non-free text. There's a lot of just structured data that goes into notes, and that's not what, it's not the optimal information, the information that a clinician actually writes down. They just click and it kind of puts information in there. All of that was removed. All of anything that would tell you that a person was their race, any indication of race was removed. We also took location out. One of the things that was very clear very quickly was you could actually predict the patient's race just on location. So when the facilities that people were being discharged to, even their area code. So for example, if someone was coming from a predominantly white suburb and their phone number was in the note, that could very easily predict their race. So all of that stuff was removed. And so this basically the clinical information that clinicians were writing about the patient remained. We used 3 different classifiers to predict race: a logistic regression model, an XGBoost, which is a boosted decision tree model, and an ensemble model. And the ensemble model basically applied the decision tree learning first, and then took the products of that and put it into a logistic regression model to do prediction. And so this is the results from the 2 data sets. And you can see here that between 74 to 83% of the time, we could predict the race of the patient. And these are the different kind of algorithms that were applied, generally speaking, but you could see the range of data. So you can see that we ended up using the logistic regression model because it's more explainable. We could take out the variables very easy to look at the coefficients and translate it to kind of human understanding a lot easier. So we ended up settling on the logistic regression learning for this project. And so one of the things that is the question is, what are the most predictive words? So these are the words and you can, we have them broken up by site. And we also, so these are the words that were predictive on the top here of Black patients. And we also categorize them. You see these colors, we tried to create categories. And so one of the things that really jumped out to us was that there were skin-related words. There were what we call personal things like race, things like Baptist, so the religion somebody had. Sickle cell, for example, is comorbidity, hypertension, and so. Those things, some of those things make sense clinically. For example, Mongolian, which would refer to a Mongolian spot in a baby, makes sense. But some of the things that also jumped out at us was things like the religion, which did not make sense for a patient. For a clinician to talk about necessarily, and also ethnicity, things like Russian for white patients. And so these are the words that, and these are the top words. There were actually a couple hundred words for each category, but the take-home message is that the process of note writing was different for there's bias in the note writing for Black and white patients, which artificial intelligence or machine learning can easily pick up, and it would affect their prediction. So the second experiment that I'm going to highlight is one where so I mentioned the bias that we saw in the workflow. And so we did an experiment where we took 9,000 patients and we looked at, and these were patients that had a deterioration event, which was unexpected transfer to the ICU. And we looked at, so each color is a different race. So blue is white, gray is Asian, and this orange in the bottom is Black. And these different lines are the different concern levels. So this is green, yellow, and red. And what you can see here is that as the concern levels go up, as clinicians pay more attention to patients, the difference between the expected percent and the actual percent of information goes up. And so this was, what told us that, and then our scoring changed by that proportion. And so this is what told us that there was really bias in the workflow that we needed to address. And so what we did was, we had to make the decision of if we were going to address this bias in the modeling or if we were going to address it in the actual prediction or the scoring. And we decided to do it in the scoring because we felt that we would be introducing our own bias if we did it in the modeling. And so we actually take these odds and apply them. We do a number of different post-processing steps. So one of the things we do is we take these odds and apply them to our score to adjust them, basically. And interestingly enough, for Asians, there wasn't much of a difference between the different concern levels going across. So the last experiment that I'm going to talk about is we wanted to, so after we'd done these adjustments and we changed how we were generating the concern levels, our question was, we actually went back and did the same analysis to make sure that we were getting a more non-biased prediction. But at the same time, we also wanted to compare concern to some of the other early warning scores or systems out there. So there's the NEWS, which stands for the National Early Warning Score, and the MUSE, which is the Modified Early Warning Score, which are popular warning scores that actually use almost 100% physiological information and to calculate deterioration. And I mentioned previously that we'd already compared how early our concern system fires to the NEWS and the MUSE. So we already knew that we were predicting earlier deterioration, but we also wanted to look at bias. And so we took 9,000 adult inpatients from 2020, and from June to December of 2020, and we looked at transfer to the ICU again, and we categorized the patients as white and non-white. And what you see here on the screen is we took what we called yellow, or the increased risk for deterioration, or the in the MUSE and the NEWS, it's kind of the middle level of risk for deterioration, and we compared them. This is a distribution of different different races. So the black and the white and the black patients. And so if the distribution was the same, there would be complete overlap, and you wouldn't see colors, kind of poking out at different points in the distribution. But to statistically do a comparison, we took the mean and we actually looked at the statistical difference between the mean of this distribution. And this is what you see here in these vertical lines. And so there was no statistically different distance between the races for concern prediction, but there was for the news and the muse. And so for us, that said that we already had validated that we were providing a prediction that was less biased, but here we also, wanted to do a comparison to other early warning scores. And so, so you might ask, so there's bias in AI. And when I say AI, AI means different things to different people. And so I just want to be clear, when I say artificial intelligence, I'm talking about applying statistical learning to data to type of mimic the way human beings make decisions or process information. And so for us, it's machine learning, but there are other ways to do artificial intelligence and other ways to implement them, not just in clinical decision support, which we do. But so what? Why is it important? And so from a clinician standpoint, I think it's important because I want to do no harm. I also, when I talk about harm, more specifically, I'm talking about what I see as missed care. So I always talk about it as unconscious bias, because I think that's what's the most constructive. And I think that clinicians, if you ask any clinician of any race, they would say that they don't want to do harm. They don't want to have missed care. And so, I think that's the important way to think about why this work that we've done is important, is because we've identified these potentials for missed care and potential harm. And also, just a couple of stats here. AI is sexy. Everybody's using it. Everybody wants it. And so you see that there's a lot of people a lot of hospitals that are using AI, and that's going to be increasing. There's already a lot of leaders who say that AI has brought great value to a lot of healthcare leaders, that they've already said that AI is improving and bringing value to their institution. And when leaders talk about value, they want to increase the value. And then finally, the percentage of AI startups has just exploded, over the last couple of decades. And so AI is not going anywhere, and it's going to be, increasingly kind of enmeshed in healthcare and in clinicians' workflow. So what can we do? Do no harm. I think it's important for us to monitor and mitigate the bias in artificial intelligence. And so one of the first things is, I think clinicians need to understand AI better. It's a clinician's job, no matter what tool they're using, to understand how that tool works and how their decisions with that tool, whether it is for treatment or diagnosis, will affect the patient, especially nurses. It's actually the nurse's job, if a physician writes an order or for a medication or clinical intervention, to make sure that's appropriate. And so it's all clinicians' job to get smarter about AI and understand the bias and advocate for unbiased AI. And then one of the problems we have in the commercial world in AI is that clinicians just aren't involved in every step of the process. And so we need to get clinicians involved, and we need to figure out better ways that clinicians and technology folks can talk to each other, understand what they're talking about, and work together to produce a product that's doesn't do harm. And so specifically with decision support, with some of the work that my team's starting to do is we're actually starting to build AI to mitigate bias in clinician workflow. And so, there's research that needs to happen. We need to understand how that type of AI can be effective. So imagine if you're a physician or a nurse and some clinical AI-powered clinical decision support says to you, you're being racist. I don't think that's going to work very well. So we have to do the research to figure out what's the best way to give that message to a clinician that'll be useful for decision support, to have them improve their clinical practice. And then when should they get it? Should we wait? Should it be passive in the sense that they can look at it later, or should it be in real time? All those questions have to be answered in research. We also have to figure out how to build this AI so that it works in implementation. And so it's not just the researching, but it's the implementation as well. And then we also have to figure out how to evaluate the effectiveness once we actually implement it. There's a lot that we don't know about clinical decision support and these types of interventions. And so we need to build the science around that stuff as well. So finally, I would be remiss if I didn't thank my team again for all of the great work that they've done to get us to where we are now. And I look forward to the work we have in the future. So thank you, everyone. And I am looking forward to questions.
Thank you. Thank you very much, Dr. Cato. I see some applause and some expressions.
Thanks, I appreciate that.
Yes, in our participants. I don't know if we are open for questions. I don't know if some of the faculty students that we have today have any question that you want to ask to Dr. Cato. I didn't see any in the chat, and I don't know if some of them are coming here. No questions? It's okay. No, I'm going to ask some of them. You have been looking into these different aspects, and definitely concern is you mentioned that is better than the traditional vital signs or physiological approaches for finding deteriorations. Do you find any particular keywords or things that give us that insight of that clinical feeling, that clinical eye that is being reflected in those notes? That
yeah, we have actually. So it's actually interesting when you look at nursing notes specifically, and the analysis that I showed before the NLP, that with my colleagues at MIT, we looked at all clinician notes. But when you look at nursing notes, and that's actually what we're using in Concern, just nursing notes. Nurses are kind of in culture to think like, if they don't document it, they didn't do it, and that there might be legal ramifications, possible future legal ramifications. So what you see is, when a nurse is concerned about a patient, they often will contact the doctor. They'll call or page the doctor, and they'll let the doctor know that, and then they'll write in their note that they made the doctor aware of their concern. So that's one of the really key concepts that you see over and over again. Nurses it's a CYA type of thing. They're just letting the whole world know, if they're going to look in their notes, that they let somebody know. And so that's one of the major concepts that you see in the note. That's true across both sides.
And interesting, that reinforced that concept that clinicians are not reading the notes unless the nurses. Then this is reinforcing the concept of,
yes,
hey, I need to speak out and tell that. And okay, from the epidemiology point of view and a statistical point of view, we use a lot of secondary data, and most of my colleagues, they use electronic health record and we do secondary analysis. Is there any concern about these biases in the way that we approach data?
I think, I think the idea that there's racial and ethnic biases in health outcomes is pretty, there's a preponderance of evidence that kind of shows that. I think the thing that is important for me for people to understand is there's also bias in the workflow. So there's bias in getting that data in, and that's something that we found a lot in concern. And then there's also, there's also kind of classic other types of bias that you have, especially in large data sets that are put out there for secondary data use. And some of them, are things like in the diagnoses and procedures, the administrative data, what we see, what we see is that, and I've seen, I used to work in the IT department, New York Presbyterian, doing analytics, and you see that each organization has a way that they bill to maximize profits, and that depends on the type of organization it depends on the type, who's the preponderance of the payer. So if they have more private payers or CMS payers, CMS is paying, and then so even the ICD-10 codes that the coders are choosing to put in the record for us here in New York is different for the same kind of concept as in Boston, for example. And so there are those biases. Another big bias that we have here at Columbia University Medical Center is we have a large Dominican population. And so there's kind of cultural issues, cultural questions like race and ethnicity that you might ask a patient here that what we chart or what we capture doesn't reflect how a Dominican person possibly thinks of themselves. So we have a lot of bad race data, because if you ask a Dominican person if they're white or black, that's not really the way they see themselves. And so it's actually kind of beguiling to me. I think a lot of the race data in the EHR is not very good for non-white patients. So things like that. And then finally for us, we thought a lot about how the data gets into the system, when it gets into the system, especially with note taking. You have to understand when a clinician is going to write the note. So all of our analyses is actually on the shift level. We realized that we couldn't get anything more discrete than the shift level, because a clinician might say that they wrote the note in the middle of the shift, but they probably wrote at the end of the shift, things like that. And so those things as well, you see that kind of information and those types of biases. There's just the EHR is still really built for billing and regulatory reasons, not clinical care. And so that's the high level lens that you have to think about EHR data.
Thank you. And now we are having a lot of questions, and I'm pleased that people is asking questions. Then I'm going to start picking some of them. And one is, if you can comment, please, in the application of this word for patients that they have limited English capacity, since the communication between the patient and the clinicians sometimes is really difficult.
So we've actually incorporated. One of the projects that we did, postdoc of mine did, was actually looked at nursing surveillance for patients who are non-English speakers, where English is not their primary language, and it was done here. So most of those speakers are Spanish speakers, and so we so on the modeling side, we had to incorporate that in because we actually found that there's even less surveillance of non-English speakers when they have a deterioration event. There's less notes written for them. There's less observation. So that was also incorporated in our modeling. On the front end, we haven't really done that much yet because our front end was for clinicians, but we actually just received a renewal to do work mostly in the pediatric space with also caregivers and family members, where we are going to have multiple language front ends. The front ends are actually probably going to look different depending on the different languages, and we're going to do focus group testing around that because to understand the concepts, and then we're also going to ask family members and caregivers if they actually feel like they are getting the same level of care as their, white or non-white other patients. And so we're going to take that feedback and see how we can actually incorporate it. And we're also going to ask if our prediction was accurate about deterioration, because in the pediatric space, family members are experts about their kids and so their loved ones. And so we're going to incorporate those predictions back into our modeling as well. So that's just some of the ways that we're in the future going to look at that.
No, thank you. Fantastic. Yes, and of course, yes, the provider is English speaker, but the front end is in that direction. But
yeah.
Of course, yes, there are some other cues or things that you can incorporate there, is what I understand. Angel is really grateful for your research and recommended solutions, and she's asking if you can offer any advice on how patients can advocate for themselves today, especially when they are meeting the clinicians.
Yeah,
How
that's
to
really
empower
tough.
that patient.
So there are more avenues in the pediatric setting than in the adult setting. Every pediatric hospital has a family advocacy office and group. On the adult side, it's really hard. I have a really quick story. I volunteered to give vaccines when the vaccines first came out. I was giving vaccines in the armory here, and there were Spanish speakers that were coming in that had other access to care issues. Like, one person I can think of, this person had a stroke, and the person who was calling to do the follow-up appointments didn't speak Spanish, and so they couldn't make the appointment, and things like that. And so I think I don't have a quick solution, but what I would say is, from my experience of having family members in the hospital and being a patient, I think patients have to feel comfortable asking questions and feel comfortable asking the same question over and over again. That's the only thing that I can suggest to make sure that they understand why a clinician is doing something, what they're doing, because sometimes that actually cues a clinician to realize they might not be doing the right thing, and there might be an error happening. And it's their health and it's their loved one's health, so they have a perfect right to ask as many times as possible, especially if they don't understand what's happening, to just keep asking.
Perfect, thank you. We have more questions, and this is from Franklin. It says, for study, thank you for your wonderful talk. Says, and for study one, he was curious how you and your team created the different categories for Black and white patients, or this was just discovered by the machine learning.
So we created the categories because we saw a grouping of words and we tried to make sense of what the grouping meant. And we actually came to it more. I was also one of the clinicians on the study from a clinical standpoint of, we would take the words and expand them to see what the words were in the notes and try to understand why they were writing that. One of the things that I think was really interesting is we saw less things about skin assessment, not skin assessment, but skin color in Black patients and white patients, which to me meant that clinicians weren't comfortable, for example, finding pale skin in a Black person or a person with dark skin, which shows that clinicians need to be better trained with non-white skin. So things like that, that's how we approached it, and that's what emerged.
Perfect.
And thank you, Franklin. I appreciate
Yes,
you.
and he just gave it you the thumbs up.
It's good
We
to
have
see you.
We have another question. How can NLP be used to assess patient social determinants of health within an electronic health record? And who is asking is not sure if this is possible.
Yeah, so that's a great question. I think one of the things that we don't do now that we need to do is actually allow both the patients and the clinicians to kind of speak more information into the system. A lot of the social determinants of health information is not captured well right now because the tools are really clunky for clinicians and really clunky for patients. And I think if clinicians were able to just have conversations with patients and ask them simple questions, and that was recorded by machine, and then the machine did NLP on that and generated lots of different types of metadata or information, social determinants of health being one of them, we'd get more of that data into the system.
Thank you. And here's an interesting question. Did you examine the nurse's race ethnicity?
No, we really wanted to, but it was a union issue. So we have a nurses union here, and the union did not want us to have personal clinician demographics. There is emerging literature that says if there's concordance of race and ethnicity with the caregiver and the patient, I mean the clinician and the patient, that there are better outcomes. And we really wanted to look into that, but we couldn't. And we really want to see, someday get to that information. But I would say that just generally speaking, when you're even in New York City, the proportion of clinicians does not reflect, the demographics of the city. So there are a lot fewer non-white clinicians than there are non-white patients. So there isn't going to be a lot of concordance.
Thank you. And the last question that I have here is, what are your recommendations to address all these places? the $1 million question.
Yeah, I think I do have one, which is we have to figure out ways in research to get community members more involved in the beginning of the research and building, doing the research and building all of these tools. So a lot of these tools are being built for clinicians, but it's the patient's data, it's their health. And we really have to start building tools where the driver is for the patients and their family members, and get them involved and really build the tools that are in a way that meets them where they are, as opposed to our assumptions about them. So it's going to take personalization because not everybody's at the same place. And we know that some non-white communities have a high burden of health disparities, and quality of care and access to care. So we need to be able to meet those people where they are with the tools, with the clinical care, and with the clinical decision support.
Perfect. And I think you answered the following question to this one. That was how we can get better data. And it was basically in that adoption of the tools. And I have new questions. Have you and your colleagues considered expanding this to Black maternal health?
We have, and we are. So we're working with a couple of teams here at Columbia, one within the School of Nursing, where we're actually looking at non-white maternal outcomes. There are two different research teams within our OB department that have one is a R01 and another one is actually a research network with 9 different academic medical centers and also a health system, where we're not just doing the modeling, but we're actually building the data structures to do the modeling right now. So it is something that we are working on, starting to work on, and what we're bringing is our modeling approach, where we're actually trying to model what the clinician's behavior is in their workflow and their thinking to understand the maternal health outcomes.
Fantastic. And I need to recognize my own bias here because as a clinician, as an informatician, I'm really passionate about all this, and decision-making support has been one of those things that I have been looking over. I don't know if there are more questions. I don't see more questions here. Dr. Kelvin. I don't know if she's available. Then, Dr. Cato, thank you very much for accepting our invitation. I think this has been a wonderful, wonderful presentation of Dr. Let me, yes, Dr. Kelvin is mute. Can we ask IT to unmute Dr. Kelvin, please? She's our. Let me see if I can unmute her and she can. Okay, now we have her back.
All right, I can unmute. I can't unmute. I can't put myself on video, but I can talk. Oh, there we go.
Perfect.
I want to thank you, Dr. Cato and Dr. Flores Arango, for a really interesting talk. I'm a little depressed now, realizing all the limitations in the data, and we really need, I mean, it just seems like such a missed opportunity to have all this data collected with all these biases that you are pointing out to us. Like, we know there are biases, and it just takes a commitment, I think, and a little effort to address them one by one. But you know, it was a great talk, and I think it opened our eyes to the potential.
Well, thank you so much. It's really, I appreciate people's time for taking the time to listen to our work, and also for the great questions. So thank you for having me.
Thank you for joining us. And thank you to the audience, and to the IT and Paolo for setting all this up, all the technical challenges that we face every day.
Thank you. And we have some questions. Will the recording be available? Yes. And last minute, how can we mobilize this info and create care algorithms to actively eliminate some of the biases?
That I don't have an answer to. I think we need to do the research to figure that out.
Correct. Yeah.
Yeah.
All right, we have our work in front of us then.
Yeah.
Thank you so much.
All right,
Thank you very much.
Everyone have a great night. Bye.